Today, we are talking about offering labor after cesarean during the time of COVID-19 and why it is more important than ever. And I should really start with introducing myself. I'm Jen Camel, VBAC Facts founder. I'm a consumer advocate, national speaker, and a continuing education provider. And I train parents and professionals across the country and really the world on the evidence on vaginal birth after cesarean. And what I've been seeing in terms of VBAC access in the time of COVID-19 has concerned me. Now, granted, I am, Lori can't hear anything. Can my team help her out? It's probably an issue with her mic or her speakers on her computer. So what I've been seeing in terms of COVID-19 is a smattering of stories. Some people say that their desire to plan a VBAC is still being honored, whereas others are told, well, you might need to schedule a cesarean earlier, or you might need to schedule an induction. And so really my goal for today is to go through what the evidence actually says. And granted, we have a lot of limited evidence. So we're going to be talking about four major points. One, why VBAC access matters now more than ever. And it's really about reducing hospital staff, reducing COVID-19 transmission and preserving hospital staff and resources. We're also going to be talking about what are the cesarean recommendations right now overall for the general population, as well as among COVID-19 cases. We'll be talking about the cesarean and anesthetic considerations for COVID-19 patients, and we'll be wrapping it up with one of the major barriers that I see in terms of VBAC access, and that is the US ACOG guidelines, the American College of OBGYN guidelines on VBAC. What kind of staffing and resources do they recommend? Is it required, etc.? So I would love to get a feel for who is in the room, and can you write down in the chat who you are, what your role is in the maternity care system, and maybe what city you're from, just so we can get a feel. So Leslie, in terms of the poll info, you're going to text VBAC Facts 486 to the number 22333. So the language. So today I'm going to be using specific types of. And first, in terms of labor after cesarean is going to be the word that I use rather than TOLAC or planned VBAC, because I think it's important to talk about what is the intention. The intention is to labor after cesarean, regardless of whether you end up with a VBAC or a repeat cesarean. And when I talk about VBAC, that was someone who plans a labor after cesarean and actually has a VBAC. And for elective repeat cesarean, those are people who schedule a cesarean before labor begins. I also use the term CBAC for cesarean birth after cesarean. And this is an alternative for people who, rather than using the phrase failed VBAC or failed TOLAC, I mean, there's no bigger sting than being told that you fail. And I want to honor the journey and be respectful to birthing parents. So why VBAC access matters? You know, often when I talk about and when I present to larger groups around the country, we delve into a whole variety of reasons why VBAC access matters. But today I'm really going to be focusing on two primary factors. One is placenta accreta, and two is the risk of COVID-19 transmission and also preserving hospital staffing and resources. So one of the things that we see with multiple cesareans is that the risk of a variety of complications increase at a statistically significant rate with each prior cesarean. And this chart actually represents a study of over 30,000 cesareans. The first was medically necessary. The rest were all elective repeats and healthy moms and healthy babies. And what we can clearly see is that as you have more and more C-sections, the risks of complications increase. And we're talking about risks like Accreta, which we'll be diving in more. So when I talk about Accreta in this sense, we're talking about Accreta, Increta, and Percreta. Postpartum hysterectomy, any blood transfusion of 4 or more units, ICU admission, and also post-operative ventilator. And so this study found a statistically significant increase for all of these factors as people have more and more prior cesareans. But today I want to dive a little bit more into advancing on to the next slide. There we go. I want to dive more into Accreta. And we see here on this graphic the distinction. It shows us the difference between Accreta, Increta, and Percreta. So Accreta is an abnormal implantation into the uterus. Increta is when the placenta actually goes into the uterine muscle. And Percreta is when the placenta goes through the uterine wall into the abdominal cavity and often adheres to other abdominal structures, most commonly the bladder. And Silver in 2010 warned us. He said that most importantly, women undergoing multiple repeat cesarean deliveries are at a substantially increased risk for life-threatening hemorrhage and morbidity in the setting of placenta accreta. These long-term maternal complications must be factored into the risk-benefit ratio for women considering vaginal birth after cesarean delivery. And so he's quite clear. This is something that everyone should be informed about when they are weighing their options of VBAC or repeat cesarean. And let's look at how the maternal outcomes differ for those who have Accreta versus don't. First, ICU admission. We can see that's substantially higher. Bladder surgical injury, maternal ventilator, reoperation, a blood clot in the lung, and also ureteral injuries. All of these are a statistically significant greater risk of occurring in birthing parents who have Accreta. But let's look at a few other outcomes. Blood transfusion, significantly higher, 54%. And in fact, ACOG quotes the rate of 70%. And hysterectomy, 20%, and uterine rupture, 2.2%. And these are, again, are all outcomes among people who have Accreta, Increta, or Percreta. But what about the infant? That's something that we hear quite a bit. And this is a chart that I find fascinating because let's look at the perinatal mortality rate for Accreta, 5.8%, considerable. And the birth weight, 43% weigh less than 2,500 grams upon delivery. And the reason for that is because there is such a high rate of preterm delivery with parents who are pregnant with abnormally evasive placentas. Now let's compare the outcomes for uterine rupture versus Accreta. Blood transfusion. And I love showing this chart because it really challenges the narrative that we're told in terms of what is riskier. So many parents are counseled to have a repeat cesarean because it successfully, almost always successfully circumvents the risk of uterine rupture. But when we compare these outcomes side by side, and then we can look at the rates that these events will actually occur, we can see quite clearly that Accreta is associated with significantly higher rates of morbidity and mortality, not only for the birthing parent, but also for their child. And so here we can see blood transfusion, Accreta, 54%, uterine rupture 12%, maternal ventilator, 14% for Accreta, uterine rupture 3%, cesarean hysterectomy, 20% for Accreta, 6% for uterine rupture, perinatal mortality, up to 7% per ACOG. And yet the guys, that's GUISE 2010 evidence report, and that was the basis for the 2010 NIH VBAC conference. On their review of maternal mortality from VBACs, they could not find one report in the studies looking, in the 8 studies they included looking at this topic, that documented one maternal death from uterine rupture. Now again, those are in tertiary level centers, and so we have to keep that in mind, but it's also important to see how striking that is. The rate of someone dying from Accreta is substantially higher than from uterine rupture. And then also perinatal mortality. And again, this is another striking statistic, 5.8% with Accreta and about 6.2% with uterine rupture. So it's important when we're talking about informed consent and informed decision making that we really are putting our feet flat on the ground in terms of what the evidence says. And here we can clearly see the rate of perinatal mortality is comparable between these two events. So the question is, and this is our first poll question, and again, for those who weren't able to respond or get your text in, you can text VBAC Facts 486 to 22333. And what I'm asking here is, what do you think? How many people pregnant after 1, 2, or 3 cesareans are informed about the risk of Accreta by their provider? So do you think it's 17%, 36%, 67%, or 93%. And as people respond, I don't know if everyone's used Poll Everywhere before, but this is an awesome program. And especially when you're presenting in front of hundreds of people, it really gives you a good idea of what the feel in the room is. And so far we've got everyone saying 100%. And I know there are more responses out there. So anyone else want to take a stab at it? You would be surprised to learn that it is actually only 7%, which I'm just realizing now that poll had an error. It wasn't 17%. The first option was supposed to be 7%, because it's in fact only 7% of people pregnant after 1, 2, or 3 cesareans are informed about Accreta when they talk to their provider about, should I plan a VBAC? Should I plan a repeat cesarean? What are the risks and benefits? And what do you recommend? And so the question I pose is this informed consent? And it's really not. You know, we need to have parents just as aware of the risk of uterine rupture and the outcomes that that could have for themselves, their babies, their future fertility, as much as they need to be aware of the risk of Accreta. How about this one? 59% of people heard the word Accreta for the first time upon their own diagnosis. So on top of people not being informed about Accreta when they're pregnant, so many of them hear about the word for the first time when they are themselves diagnosed. So that's just unconscionable, and we can do better for pregnant people. So what do women say? Well, one woman said, I heard not a word about Accreta until my 4th pregnancy, all prior C-sections, when I was 19 weeks along. We sadly only made it to 22 weeks with Accreta with bladder involvement. My regular hospital felt unable to deal with my case, and I was transferred to the specialists at Johns Hopkins. Another woman said nothing, never knew it existed. When I was told I had complete placenta previa this time, I asked about Accreta, and the doctor said that never happens. Ended up with Accreta. Now, one of the things that is important to note is that when someone is diagnosed with Accreta, when someone is diagnosed with placenta previa, their risk of developing Accreta, increta, or percreta dramatically increases. And that relationship also strengthens with the number of prior cesareans someone has. Our 3rd person said, I was told I was not a candidate for VBAC during my 2nd pregnancy due to the risk of uterine rupture because I was told I had a thin uterus. 3rd baby was my Accreta baby. Finally, we have, and that's a real quick review about Accreta. I have so much more in my longer trainings, but I just really wanted to give a quick flavor of what is at stake when we talk about routing people into repeat cesareans. But I also want to really make sure that we're looking at what ACOG says about medical ethics. And they talk about, in their committee opinion on medical ethics, the welfare of the patient is central to all considerations in the patient-physician relationship. The respect for the right of individual patients to make their own choices about healthcare autonomy is fundamental. And ACOG is clear this thread is strong throughout all of their guidelines, including their guidelines on VBAC. But today, it's so much more than just what is going to happen in the next pregnancy. We also have the threat of coronavirus and what this means in terms of birthing people. So I want to dive right in with what the CDC is recommending and what are their COVID-19 goals. Well, their key goals for the U.S. healthcare system in response to the COVID-19 outbreak are to, first, reduce morbidity and mortality. Second, minimize disease transmission. Third, protect healthcare personnel. And 4th, preserve healthcare system functioning. And so really, what does that mean in terms of maternity care? What are our goals? Well, really, the faster healthy parents and babies can leave the hospital, the lower their risk of becoming infected with COVID-19, and hospital staff and resources can be directed to COVID-19 patients. That's really the big picture here, is that the longer someone is in the hospital, the more resources they're using, and also the more likely they're going to transmit or receive COVID-19. So what does ACOG say about expedited discharge? And they said, actually, we should, to limit the risk of inadvertent exposure and infection, it may be appropriate to expedite discharge when both the mother and the infant are healthy. For example, discharge may be considered after day 1 for women with uncomplicated vaginal births, and after 2 days for women with cesarean births, depending on their status. Early discharge will require discussion with the facility's pediatric care team and should be linked to home telehealth visits with the mother and infant. Now, the Society for Obstetricians and Gynecologists out of Canada also is recommending delayed admission, and they say expected management at home may be appropriate for some women. So we're talking about not only expediting discharge, but delaying admission, again, to fulfill that goal of reducing the amount of time someone who is pregnant is admitted to the hospital. And VBACs also use less resources. A study in 2018 said that VBACs result in a reduced length of hospital stay postpartum relative to cesarean and is associated with fewer long-term maternal morbidities, such as hysterectomy, placenta previa, which is when the placenta implants low on the uterus, and mortality. But let's look at hospital stay by outcome. I actually found this. Of course, I'm going to use this word a lot, maybe fascinating. Maybe this should be a drinking game because I think it's all pretty fascinating. But let's look at the number of hospital days by outcome. And for someone who has a cesarean hysterectomy, the average stay is about 11 days. Operative injury, which is about 6, and that's more common during a cesarean. I was interested to see, not fascinated, that elective cesarean, emergency cesarean, someone who has a blood transfusion, and a uterine rupture all tend to be in the hospital for about 5 days. VBAC with a vacuum is 3 days, and just a straightforward VBAC is 2 days. And so we can clearly see here how someone who has a VBAC is using less, is staying at the hospital for a shorter amount of time, reducing the risk of them contracting coronavirus, as well as reducing the staffing and resources that they're using. I also want to show this study, and again, this is going back to the Silver 2006 study of over 30,000 repeat cesareans, 30,000 cesareans total, most of them repeats. And they found that the number of hospitals, the hospital stay increases at a significant rate with each prior cesarean. And so as someone has more and more cesareans, their hospital stay will increase. And also, VBACs use less resources and money. Another study out of 2013 said a TOLAC is less expensive and more effective than a repeat cesarean section in a group of women with balanced baseline characteristics. So that's about solely, specifically VBAC. But I want to look now at what are the current COVID-19 guidelines. And this tweet by Dr. Moradi really gives us an idea of what the state of affairs is. He recently said, "There's a somewhat encouraging study of 5 patients published in JAMA," I said, then realized how insane that statement sounds and how much the world has changed in a few short weeks. And he's absolutely true. Right now, there are a lot of opinions and very little evidence. And I'm going to share it all with you, what is specifically relevant to cesareans and anesthesia. There is so much information out there. And I was working on this up to about 20 minutes before we started because I just would find more and just jam it in there. So let's get to it. So one of the studies that I looked at talked about how they chose elective cesarean delivery. And I'd love to read this quote to you. They say, "To ensure the safety of the birthing parent and newborns, we chose to perform elective cesarean delivery. Although we recommend elective cesarean delivery, there is a paucity of data to drive these recommendations. The final choice for the delivery method needs to consider the birthing parent's condition, the wishes of the patient, and the advice of the obstetrician." And so that's a really important passage to read because they recommended elective repeat cesareans or elective cesareans for all of their patients, but then they acknowledge that there's actually no data to support that recommendation. And I think it's really important for not only providers, but for parents to hear that you may be hearing people say, whether you've had a prior cesarean or not, that just choosing an elective cesarean delivery is the best route. But the truth is, we don't have good data to actually support that recommendation. Let me walk you through it. So the CDC is actually recommending that we reschedule elective and non-urgent admissions, as well as delay elective surgical cases. And another study recommended that we must make a transition to military medicine-like planning. Rational protocols and rapid action are essential in order to stem the spread of disease and anticipate the inevitable shortage of material and human resources. So what does that look like? Well, first, let's talk about, is anyone encouraging elective cesareans for the general population? And the short answer is no. Not the WHO, not the CDC, not the Royal College of Obstetricians and Gynecologists out of the UK, not the American College of Obstetricians and Gynecologists out of the US, and not the Society of OBGYNs out of Canada. No one is recommending elective cesareans for the general populations. And one study stated the C-section or instrumental deliveries for obstetric indication or deterioration of maternal condition only. So again, just as before, just as pre-COVID times, cesarean should be performed when medically indicated. So what does ACOG say about personnel and resources? Now they say that inductions of labors and cesarean deliveries should continue to be performed as indicated. And decisions on how to schedule these procedures in the time of the COVID-19 pandemic are best made at the local facility and systems level, with input from obstetrical care professionals and based on healthcare personnel availability, geography, access to readily available local resources, and coordination with other centers. Now, how about inductions for the general population? That's another thing I've heard. People being told, well, you should come in and be induced. Is anyone recommending that? And again, it's no across the board. The WHO, the CDC, and major obstetrical guidelines out of the UK, US, and Canada. No one is recommending inductions for the general population. And in fact, a systematic review on COVID-19 and pregnancy found that despite there not being solid recommendations for the general population, or, which I'll be showing you in a bit, recommendations in terms of COVID-19 cases, this study found that the use of C-section was a common mode of delivery among the COVID-19 infected pregnant women than their counterparts. And they found that 85.4% of those who had COVID-19 had C-sections. So is there evidence to support this? The answer is no, across the board. Cesareans are not being recommended for COVID-19 patients. So the WHO says, and let me actually pull up my longer quote that I wanted to read you. The WHO says cesarean sections should be performed when medically justified. The mode of birth should be individualized and based on the woman's pregnancy preferences alongside obstetric indications. The Royal College of OBGYNs says no. With regard to both mode of birth, an individualized decision should also be made with no obstetric contraindication to any method for COVID-19 cases except water birth. Cesarean section should be performed if indicated based on maternal and fetal condition as in normal practice. So what does ACOG say? ACOG also says no. They say cesarean delivery should therefore be based on obstetric, fetal, and maternal indications and not COVID-19 status alone. In the event that an individual should request a cesarean delivery because of COVID-19 concerns, OBGYNs and other obstetric care professionals should follow ACOG's guidance provided in Committee Opinion 761, Cesarean Delivery on Maternal Request. How about the Society of OBGYNs of Canada? They also say no. They say cesarean delivery should be reserved for obstetrical indications. And Chen, which is the largest study that I could find on cesareans in COVID-19 patients, and I wanted to include their, and we'll be diving into them more later, but I wanted to include their quote here. They say, again, no, and the mode of delivery should be based on the usual obstetric indications, as there is no clear benefit of delivery via cesarean in women with COVID-19 infection. So across the board, cesareans should not be, and when I should qualify here, elective cesareans are not recommended for COVID-19 patients. Of course, when it's medically indicated, absolutely. So what does ACOG say in terms of COVID-19 and delivery timing? So they say timing of delivery in most cases should not be indicated by maternal COVID-19 infection. They say for women with suspected or confirmed COVID-19 early in pregnancy who recover, no alteration to the usual timing of delivery is indicated. Now, for women with suspected or confirmed COVID-19 in the 3rd trimester who recover, it is reasonable to attempt to postpone delivery if no other medical indications arise until a negative testing result is obtained or quarantine status is lifted in an attempt to avoid transmission to the neonate. And finally, in general, COVID-19 infection itself is not an indication for delivery. So how about the Royal College of OBGYNs out of the UK? They say, considering delay of elective cesarean birth or induction for women with symptoms suggestive of COVID-19, as well as those with confirmed COVID-19. And this is critical. Individual assessment should consider the maternal condition, the fetal condition, the potential for improvement following elective birth, and the gestation of the pregnancy. The priority must always be the well-being of the mother. How about the Society of OBGYNs out of Canada? They say elective cesarean delivery should be delayed, if possible, until a woman is no longer considered infectious. So what about operative delivery? Well, one study suggested that, and really this wasn't actually a study, this was a commentary, so this was an opinion piece. But I think it's important to throw in there because we're bringing it all together today. So they say that whenever possible, vaginal delivery via induction of labor with eventual instrumental delivery to avoid maternal exhaustion should be favored to avoid unnecessary surgical complications in an already sick patient. Septic shock, acute organ failure, or fetal distress should prompt emergency cesarean delivery or termination if legal before fetal viability. So this study is urging, or this individual's opinion is expressing, that operative delivery is still preferable over cesarean section. Another study talked about managing staff and resources, and they referenced other disasters in the past and how hospitals have been able to tier their resources and be able to conserve resources. And so they said, as seen previously, non-systemic modification of procedural schedules, such as canceling non-essential surgery cases, as well as adjusting admission and discharges, were shown to reduce occupancy and demand of non-urgent hospital resources after the New York attacks in 2001 and after the SARS Toronto outbreak in 2003 by 9% and 12% respectively. So what does that look like? Well, this is actually this is what another study talked about. And so they took all surgical services and they put them into 4 different categories. The first, category A, were procedures with no impact on inpatient capacity. B were procedures that could be delayed indefinitely. C were procedures that could be delayed by a week. And D were procedures that could not be delayed. And what this study found is that by delaying categories B and C, there was an 8% reduction in inpatient occupancy. And so that is considerable and significant considering how stressed some of the hospitals are already in the US and how many will be stressed over the coming weeks. Now, another study looked at a tiered approach to OB services, which is specific to what we're discussing today. And so what they really wanted was a coordinated case cancellation postponement program or management system. And their goals were really to conserve and protect the health and maternity care providers in particular, as well as PPE. And one of their arguments was, maternity care providers, we need them to be able to be healthy and continue serving the community because people are pregnant and need to deliver. Now, this process is actually already in use for OBGYN surgeries at the University of Florida, and they use it to guide decision making. And when should you implement this? Well, this study recommends that when you have local community transmission is the time to implement this. Now, there was a lot in this study, but I just pulled out the things that were relevant to what we're talking about today, and that's namely C-sections. And so they recommend that scheduled cesarean or labor inductions can be delayed 7 to 14 days, and be scheduled strategically based on hospital resources. Now, to be clear, emergent cesarean and emergent cesarean hysterectomies should not be delayed for any reason. But that was one of the ways that they're able to modulate the pressure on staffing and resources. Now, I just want to throw this out here that vertical transmission, I read a few articles, and I'm sure you have too, of cases here, cases there, but ACOG is still saying that there is no conclusive evidence of vertical transmission of COVID-19, and I saw that same thread through other guidelines. So even though we're seeing individual cases, we still do not have conclusive evidence of vertical transmission. So let's talk about PPE recommendations by event type. How do the recommendations vary depending on a vaginal delivery or a cesarean? So let's first back up and talk about when is PPE necessary or recommended. And it's really for aerosol generating procedures. And so coughing and sneezing are known to release aerosols. However, it is thought that aerosols generated by medical procedures pose a more significant risk to infection transmission. So that's an important thing to keep in mind. In terms of vaginal delivery, there's a variety of different opinions out there. And we're going to see that throughout today's training, is that there are a variety of different opinions because we just don't have solid data. So the Society for OBGYNs out of Canada says there is no data to indicate that the second stage of labor generates aerosols, and as such, droplet or contact precautions are sufficient for vaginal delivery. Now, the American College of OBGYN says, although a person with suspected or confirmed COVID-19 would normally be instructed to wear a mask, active pushing while wearing a surgical mask may be difficult, and forceful exhalation may significantly reduce the effectiveness of a mask in preventing the spread of the virus by respiratory droplets. But we also have a third opinion, and this is again that Swiss study that was talking about preparing for COVID-19 and other pandemics and emergencies. They say consider obstetric assistance for vaginal birth as assistance maneuvers that can produce aerosols. And so use FFP2 and FFP3 facial filters, disposable water repellent TNT long sleeve gown, double gloves, visor or goggles, disposable headgear, shoes, and proceed for disposal in accordance with appropriate standards. Now, the CDC on conserving PPE, I'm going to mute someone here real quick. Just be sure that you're muting yourself if you're logging on via Zoom. I'm going to call you out, Natasha, if you could. There we go. So what does the CDC say on conserving PPE? They said that carefully prioritize PPE use for selected care activities. This would include reserving sterile gowns and gloves for urgent sterile patient procedures such as surgery, and reserving respirators for aerosol generating procedures and patient care with airborne transmitted disease risks like tuberculosis, measles, and brucella. Now, how about PPE when you're caring for those who are confirmed to have COVID-19? So ACOG says in terms of all deliveries, all medical staff caring for potential or confirmed COVID-19 patients should use personal protective equipment when available, including respirators or face masks, eye protection, gloves, and gown. Now, in terms of surgeries, The Society for Obstetric Anesthesia and Perinatology recommends that anesthesia providers and necessary assistants should implement droplet and contact precautions with eye protection and ideally airborne precautions, gown, glove, and ideally N95 with face shield or PAPR. Now, in terms of general anesthesia, what should people be remembering? Well, general anesthesia is an aerosol generating procedure, significantly increasing the risk of coronavirus transmission to attending staff. And we're going to be talking about a study that reviews PPE and coronavirus transmission among anesthesiologists or anesthetists. The SOAP 2020 says to minimize to only essential personnel during intubation. All personnel present for intubation should wear an N95 mask. And the Royal College of OBGYN says that all staff in theater should wear full PPE, including a filtering face piece level 3 mask, and the scrub team should scrub and don PPE before the general anesthetic is commenced. What about regional anesthesia? So the Royal College of OBGYN says that all staff not required for the sitting of the general anesthetic should stay outside the theater until the block is effective. And the Society for OBGYNs out of Canada says that given that intubation is considered an aerosol generating procedure, the surgical team should wear N95 respirators for cesarean delivery in case there is a need to convert from regional to general anesthesia. So what about COVID transmission to anesthetists? Well, my team and I found one study looking at 49 COVID-19 spinals administered by 44 anesthetists. And they found that 84% of those anesthetists used level 3 PPE and 11.4% contracted COVID-19. So when we looked at those who contracted COVID-19 and the level of PPE they had, 2.7% of those with level 3 PPE contracted COVID-19 versus 57.1% of those who used level 1 PPE contracted COVID-19. And so this study concluded that level 3 PPE helps prevent or reduce the rate of COVID-19 transmission. So now is really the time to offer VBAC, and that's because VBAC has future long-term complications, it frees up beds, it frees up staff, it reduces hospital stays, and it also reduces transmission and uses less PPE. But going a little quick there, heavy on the accelerator. Okay, so I want to talk about the safety of anesthesia for COVID-19 patients. This was the largest study that I could find. And again, let's think of our Twitter quote earlier, it only includes 89 people who had COVID-19. And they compared their outcomes versus 173 who did not have COVID-19. This study was out of the Hubei province, and it looked at 3 hospitals there. Now, it's important to note that this was a preprint and it hasn't been peer reviewed, but I wanted to share it with you because it is the largest study that my team and I could find to date. And what they concluded was that anesthesia-related complications occur more frequently in the COVID-19 birthing parents, and their newborns have a high risk of distress. So let's dive into those outcomes. First, they found that those who had COVID-19 were significantly more likely to require an emergency cesarean. In fact, almost 70% of those who were COVID-19 positive had an emergency cesarean, as opposed to about 38% of those who were COVID-19 negative. What were the outcomes among those who had general anesthesia? And again, they're comparing those COVID positive to COVID negative. Well, those who were COVID positive had significantly more pain in the pharynx, significantly more hypotension. Look at that, 27% versus 0%. Operative time, 69 minutes versus 57 minutes. Hospital stay, almost 14 days versus 7 days. Post-operative oxygen therapy was almost 24 hours versus 10 hours. And intraoperative Pitocin, I added that in here, that was not a significant difference between positive and negative people. But I wanted to show the high rate of intraoperative Pitocin. It was almost 82% in positive versus 78% in negative. And I'll talk about why that's relevant in just a touch. So regional anesthesia It took longer to place, 7 minutes versus a little bit over 6 minutes. Multiple punctures were more likely among those who were positive. Also, hypotension. Check that out. 72% were hypotensive versus 20% who were negative. More nausea, vertigo, and chills among positive. Operative time, again, longer, 60 minutes versus 55 minutes, and the hospital stay, 12 days versus 6.5 days. Intraoperative Pitocin use, 42% versus 26%, and postoperative oxygen therapy, about 15 hours versus 9 hours. So let's go back to our intraoperative Pitocin use. So they had these very high rates of hypotension, and they actually attributed those to the anesthesia and to the preoperative fasting. Now, they also did not record any postpartum hemorrhages. So I wonder how much of that was possibly related to their intraoperative use of Pitocin to mitigate bleeding. So what about the babies born to COVID positive parents? For those who had general anesthesia, they were significantly more likely to have a 1-minute APGAR of less than or equal to 8, 73% versus 11%, as well as a 5-minute APGAR of less than or equal to 8, 45% versus about 5.5%. Now note, all of the general anesthesia babies were sent to the NICU. Let's look at regional anesthesia. 1-minute APGAR, again, we see that a significantly higher for COVID positive patients, but a significantly lower rate, only 5.1% versus 0.6%. And again, NICU admission, all of the COVID positive patients or babies, let me rephrase, all the babies born to COVID positive parents went to the NICU versus 2.6% who were negative. Now, it's important to note, there were no newborns who were diagnosed with COVID, and there were no neonatal deaths. But in the abstract, they will talk about how there was a significantly higher rate of NICU admission for babies born to COVID positive parents. But when you read the text, you learn that all babies born to COVID positive patients were admitted to the NICU for precaution of further care. So these babies were admitted to the NICU as per policy, not because anything was wrong with those babies. And I think that's really important to point out. What are some notable considerations with this study? Well, first, they said that epidural is superior to spinal for COVID-19 patients because the coronavirus may be present in the central nervous system. They said that general anesthesia results in more hypotension and a high risk of exposure to medical staff and should be avoided unless it is inevitably used for emergency cases. And you will see that as one of the major themes. Almost every single study that we were able to find on anesthesia and COVID-19 made this same general statement. General anesthesia should really be avoided unless it is absolutely necessary. And due to higher rates of hypotension, it is necessary for COVID-19 patients to have a contingency plan in place for the high risk of obstetric hemorrhage. So that's important to keep in mind. And cesarean delivery increases the risk of microenvironmental aerosols. And this was actually their rationale for separating the birthing parent and baby. And I wish we had time to go through all of that. We don't. But I will include in the handouts a wonderful summary of all of the back and forth about separating babies and mothers. Now, COVID-19, another study on COVID-19 positive anesthesia complications. Again, look at this small study. 14 confirmed, 16 suspected, 30 total out of Wuhan. So this is the second largest study that we could find, 30 patients. So that just gives you an idea of how limited the data is right now. And what they said is in cesarean section for pregnant women with COVID-19 infection, combined spinal epidural anesthesia was safe and efficient in achieving satisfactory obstetrical anesthesia and postpartum analgesia. What were their major findings? Well, they found that there were no severe maternal complications related to anesthesia or surgery, and that included incision wound infection, postpartum hemorrhage, intestinal adhesions, intestinal obstruction, or blood clots. They also had no coronavirus transmission to babies, no cross-infection to healthcare workers. They did find that those who had coronavirus, who were COVID-19 positive, had more bleeding, but again, you can see it was relatively small, 336 milliliters versus 294 milliliters. And also those who are COVID-19 positive had a longer time to the first anal exhaust, which is basically the first time passing gas, about 20.7 hours versus 16.5 hours. Now, what were the considerations for this study? So they said anesthesiologists had a high exposure risk to coronavirus when conducting cesarean section for pregnant women with pneumonia. So what did they do? Well, they dedicated one negative pressure operating room for all operations on pregnant women with confirmed COVID-19 pneumonia. And they had cesareans on suspected cases occurred in 2 other ORs in the designated area. Now, it's also important to note that all of the participants in this study were in their 3rd trimester and had a mild infection. In fact, most did not show any respiratory symptoms on admission. And so this study said that their findings may not be applicable to those experiencing moderate to severe symptoms. Here's our 3rd study. They looked at 17 COVID-19 positive people in Wuhan, and they found that the incidence of hypotension during epidural anesthesia appeared excessive. Proper patient transfer, medical staff access procedures, and effective biosafety precautions are important to protect medical staff from COVID-19. So what did they find? Well, they actually found that 86% of those who had epidurals experienced significant intraoperative hypertension. And they actually say that this is because early studies indicate that the circulatory system is highly susceptible to the coronavirus infection. They had, the other 3 people had general anesthesia due to emergency surgery. There were 3 premature neonates, but no deaths or serious neonatal asphyxia events, and no medical staff were infected throughout patient care period. So what are the things that we should keep in mind when looking at this study? Well, the epidural or combined spinal epidural anesthesia were the first choice to avoid endotracheal intubation, which could induce or exacerbate pulmonary complications in patients with COVID-19. And again, they say general anesthesia should be reserved for emergencies. Now, they had no staff infected. So how did they do this? Well, they first had a negative pressure operating room that was just for COVID-19 people. They also had proper patient transfer via a specific patient negative pressure transfer vehicle. They had medical staff access procedures and also effective biosafety precautions. So let's talk, we've got 9 minutes left, people. So I might go a little bit later, and for those who want to stick around, you can. I have the major points about ACOG's guidelines at the beginning, and I will be answering questions at the end. But I want to really dive into what are ACOG's guidelines in theory and in reality, because ACOG's guidelines are one of the major reasons why hospitals in America say they can't attend VBAC. But let's break it down. So, you know what? I am not going to do this poll just in the interest of time. What is the one common thread between all facilities and providers that offer VBAC? Now, I'm sure you have a lot of ideas. The one common thread is motivation. It is simply the desire to offer VBAC. And let me show you more about that. So we're going to be talking about 3 major things. What does ACOG actually say? What did they intend? And how are their guidelines interpreted? So first, let's talk about what did they actually say. So ACOG supports VBAC, and in their latest guidelines from 2019, which is an interim update for their guidelines published in 2017, they say the preponderance of evidence suggests that most women with 1 previous cesarean delivery with a low transverse incision are candidates for and should be counseled about and offered trial of labor after cesarean. So they're very, very clear. They support VBAC. Now, they're also very clear about what type of facility should be offering VBAC. And they say trial of labor after previous cesarean delivery should be attempted at facilities capable of performing emergency deliveries. Women attempting TOLAC should be cared for in a level 1 hospital, i.e. one that can provide basic care or higher. So let's also talk about what ACOG, the ideal VBAC setting. And so ACOG says none of the recommendations made by ACOG should be used to avoid appropriate efforts to provide the recommended resources to make TOLAC as safe as possible for those women who choose this options. So they're really saying we are setting up what we believe to be an ideal setting, but at the same time, it is still the patient's decision on whether they want to proceed with a VBAC in a hospital with lower or less or more resources. And I'll be talking more about how to offer VBAC and how hospitals do offer VBAC in low resource settings. That's how we're going to be closing up the training today. Now, what about hospitals that don't offer planned VBAC? What does ACOG say should happen? Well, they're very clear that respect for patient autonomy also dictates that even if a center does not offer TOLAC, and that includes hospitals that offer VBAC bans, such a policy cannot be used to force women to have a cesarean delivery or to deny care to women in labor who decline to have a repeat cesarean delivery. And they even go far to say coercion is not acceptable. So whenever we talk about VBAC, I really want to make sure that everyone has access and has reviewed and digested and knows this committee opinion by ACOG, the refusal of medically recommended treatment during pregnancy. And I'll include it in the handouts for those who registered via vbacfacts.com/COVID-19. But it outlines step by step how providers should react when a patient exercises their right to informed refusal. So 3 things to consider. Second thing, what did ACOG intend with these guidelines? And they are very clear. Did ACOG really intend to limit VBAC access to only hospitals with 24/7 anesthesia? Is that their intention? Because that's what so many people believe. But let's take a look. ACOG's intentions are clear, and they actually said restricting access to planned VBAC was not the intention of this immediately available recommendation. And in fact, 24/7 anesthesia is unrealistic in America, and there's a few different reasons for that. One, there's not enough anesthesiologists in America to provide that level of coverage. Second, anesthesiologists are aging out. I mean, if you look at a chart of anesthesiologists by age in America, you'll see a huge bump among those who are 50, 60 years old. They're aging out, and not many doctors are choosing anesthesia. And so we don't have people coming in the pipeline, and we have people exiting at the end. And smaller hospitals simply cannot afford it. And if ACOG really wanted hospitals to offer 24/7 anesthesia, in order to offer VBAC, they could have used incredibly simple, clear language to make that clear. Just like how they use clear language in terms of level 1 hospitals. They would have said hospitals have to have 24/7 anesthesia in order to offer VBAC. But they did not do that, and they have not done that. So the reality is that is not what ACOG intended. And again, we go back to this very clear language. Women attempting TOLAC should be cared for in a level 1 center. That is what ACOG says. ACOG does not say you have to have 24/7 anesthesia. Now, we're not going to do this poll just in terms of time, but if 24/7 anesthesia was enforced in all hospitals, the truth is 75% of labor and delivery units would close. That would be the reality. That's not okay. And we can't permit that to happen. So we can't hold ourselves to this standard that would result in 75% of labor and delivery units closing. So the third thing, got 3 minutes to spare, let's see if we can do it. How are the guidelines interpreted? And this is the key thing, because how hospital administrators interpret ACOG's guidelines impacts VBAC policies. Let me show you what I mean. So Dr. David Birnbach was preparing to present at the 2010 National Institutes of Health VBAC conference. And in preparation for his presentation, he called 6 hospitals in his hometown of Houston, Texas, and said, hey, what's your VBAC policy? And he got, not surprisingly, 6 very different answers. And let me walk you through them. First, in-house for all key players. Second, in-house for anesthesia, but OB not in-house. Third, less than 20 minutes for anesthesia and OB. 4, less than 15 minutes for OB, 20 for anesthesia, nursing in-house. 5, less than 15 minutes for anesthesia, 20 for OB, no rule for nurses. And 6, less than 15 minutes for OB and anesthesia, and 20 minutes for nursing. Now let me ask you this question. If there was a standard definition about what ACOG meant, if there is a standard definition for what hospitals need to offer in order to offer VBAC, don't you think there'd be at least 2 hospitals here who had the same answer? They don't. And that's because hospital policies vary, and it really varies by the motivation to offer VBAC. So let's look at California hospitals with 24/7 anesthesia, because that's what so many people say, right? Hospitals with 24/7 anesthesia, they're the ones who have all the capability of offering VBAC. So really all of them should be offering VBAC, right? Because they meet this most conservative interpretation of what immediately available means. But let's look at this chart here. You can see that 29% of California hospitals with 24/7 anesthesia ban VBAC. Yes, 1/3 of hospitals that meet the most stringent interpretation of what ACOG intended ban VBAC. And a 2-year study of California hospitals of California labor after cesareans found that utilization and success rate of TOLAC, however, varied considerably across hospitals. An adjustment for patient and clinical risk factors had little impact on the variation. Now, why is California data important? Well, California data is important relative to the US because 1 in 8 births in the United States happen in California. And in California, we have a wide range of urban and rural hospitals and areas. And so by looking at what's happening in California, you can get a good snapshot of what's happening nationwide. Now let's look at another study that looked at 24/7 anesthesia coverage. Now they found among hospitals that were considered high LAC or VBAC hospitals, 64% had anesthesia. Now, what do you think it would be for those who were not considered high LAC and VBAC hospitals? 54% of them had 24/7 anesthesia. So again, this isn't an issue of staffing or resources. This is an issue of motivation. And a lot of hospitals simply opt out of offering VBAC. So when we look at all the hospitals in California and we say, okay, all the hospitals in California that had 24/7 anesthesia, 44% were considered high LAC VBAC hospitals, but 56% were not. So again, why are these hospitals with 24/7 anesthesia not offering VBAC or not significantly offering VBAC? And if just hospitals with 24/7 anesthesia offered VBAC, we could dramatically increase not only VBAC access, but decrease COVID-19 transmission among these individuals. Now, this is a quote, and I'm not going to play it because we're coming up on time, but basically this is Dr. Howard Mickoff, and he's saying it's not about being equipped. Who offers VBAC is not an issue of who is, quote, equipped to do so. It's more of an issue of who is willing. And there are plenty of hospitals around the country, around the United States, who simply opt not to offer VBAC. They just say, we don't want to do it, we're going to ban it, and I'm going to add this little part, from my opinion, they're going to package it under the guise of patient safety, when in reality is they just don't want to offer it.
Should we start?
So, finishing up, and we are actually going to do it with just a few minutes over, so hang in with me there, because this is when we talk about supporting VBAC and low resource settings. And Jimmy, could you just mute yourself there real quick? There, I did it for you, love, thank you. So supporting VBAC and low resource settings. So this is our first case study, and this is from Dr. Jean Howe. She actually got up and spoke during the 2010 NIH VBAC conference, and she talked about the Navajo Nation and their VBAC statistics. And she shared how she represented 5 rural underfunded hospitals and how they collectively delivered 3,000 babies each year. They did not have 24/7 anesthesia, and yet they had a 15% cesarean rate. And anyone want to guess what their VBAC rate was? 38%, which is actually a pretty high rate. And that's 10% higher than the national peak that we had back in the 90s. So this is just one story of one hospital who was able to offer VBAC and do so because they're motivated to offer it, and they want to offer it, and they prioritize it as a public health initiative. Now, this is our second case study. And this is a level 1 hospital up in Canada. And I want to share what this particular physician said. She said, our level 1 hospital with just 60 deliveries per year is located in Golden, British Columbia. Our hospital serves a population of about 10,000. We have 4 general practitioners and 1 midwife providing maternity care in a group model. We have 1 general surgeon and 1 locum GP surgeon providing cesarean call. Everyone is on call from home. We have been offering VBAC and TOLAC since well before she came there, which was in about 2011. We all believe strongly in shared informed decision-making and believe that our patients should have a choice and be supported while being given the best information possible about the risk. So how do they do that? She said, well, we tell our patients that if there were to be a uterine rupture, we would not be able to do a cesarean as quickly as they could in a big hospital. And the risk of a bad outcome for the baby is therefore higher. Of our patients who want a TOLAC, I'm not aware of any who have chosen to deliver in the city for this reason. Over the past few years, we have had many successful VBACs, 1 nurse and 1 physician colleague as well. Our referral center is 3 hours south of us, and there are OBGYNs and pediatricians there, but they also do not have in-house OR after hours, and they also offer VBAC. There are 3 other smaller hospitals in our region with populations similar to ours that are run by GPs and GPs with extra surgical skills who provide cesarean section call. And to my knowledge, all 3 of those hospitals also offer VBACs. So striking, so different than what we are led to believe in the United States in terms of who offers VBAC and who doesn't. Now, here's a 3rd case study. So this is Dr. Katoska, and he says that this issue extends to a majority of level 2 centers like ours that also do not have in-house surgical capability at night or on weekends. Many offer VBACs. To account for the difference in surgical response time, we have modified our consent slightly. Well, how do they do that? So they say the risk of rupture and spontaneous labor is about 1 in 200, regardless of rapidity of surgical response. The difference in risk lies in the likelihood of poor perinatal outcome if a rupture occurs. Now, in tertiary centers with a 24/7 in-house coverage, the risk is about 1 in 10 per land in 2004 for a composite risk to the fetus of 1 in 2,000 of HIE or death from uterine rupture. In other words, they rescue about 9 out of every 10 babies when uterine rupture occurs. And again, I'm reading Dr. Katoska's words here. There is not good evidence how much the risk increases in a center without in-house surgical capability. Now, we estimate that it doubles the risk to 1 in 5 per rupture or 1 in 1,000 per labor. Given our close calls over 12 years of regular VBACs, I believe this is a reasonable estimate. We disclose this difference in risk in our consent form. If a woman feels that 1 in 2,000 is acceptable, but 1 in 1,000 is not, we refer her to a tertiary center. I have not had a woman decide to leave for this small difference in risk. Our last measured successful VBAC rate was 24% of all women with a prior cesarean. Now, I just want to reflect on these words for a little bit here. I want to point out a couple things. First, it's not hospital policy that is dictating mode of delivery, right? They're not saying we've banned hospitals because we don't have 24/7 anesthesia. Banned hospitals. We've banned VBAC because we don't have 24/7 anesthesia. They're saying, let's be honest with our clients about what we know. Let's tell them what the risks are in a tertiary level hospital. Let's estimate what those risks could be at our community hospital. And let's give our clients the option of saying, I accept that level of risk, or I don't, and I'm willing to drive to a tertiary level hospital. I believe you said it was 3 hours away. That is how it should be. That is what we should be doing in the US. We should be giving the power back to the patient and being honest about what our capabilities are and being honest about what the risk is. And notice he's not saying 5% risk or 25% risk like I've heard so many parents told. He's giving an honest assessment of what the risks are. That is what we should be doing. That is what autonomy is about. So let me give a 4th case study. And this was actually of a level 1 hospital who reversed their 10-year ban. Now, why did they have a ban? They had a ban because they didn't have 24/7 anesthesia. And so what they did was that they came up with a compromise. Okay, we'll have anesthesia in-house during active labor. And they found that the average time per labor after cesarean for anesthesia to be in-house was only 4 hours. Now, what they did with the anesthesiologists is they paid them a flat rate for a 24-hour period. So whether that anesthesiologist attends 1 VBAC or 4 VBACs over a 24-hour period, they get the same rate. What do they have? An 80% VBAC success rate, because we had a motivated physician and a perinatologist create a plan, write a policy, and then go and meet with all of the individual groups who were needed to be talked to in the hospital to propose this plan, and got it approved. It took about 2 years. It's quite a long time, but they were able to do it. And now an 80% success rate in a community hospital without 24/7 anesthesia. My point in sharing this to you is that it can be done. I want to show you that there are a variety of different hospitals with a variety of different staffing levels that offer VBAC. And they do so because they know it's important, they know the evidence supports it, and they know it's important to their community. So VBAC access is critical to the public health, and I'd just like to note we're only 9 minutes over. Yay! So VBAC access is critical to the public health. One, the evidence supports VBAC safety. And we didn't get into that so much today. I do in my longer trainings, but really, I mean, as you can see, we're really jam-packed with everything we covered. Guidelines encourage access, and that's really across the board. That's from out of the US, that's out of Canada, that's out of the UK. When we look at guidelines around the world, they are pretty consistent that they encourage access to VBAC. We know that VBAC has fewer complications long-term, and one that we really focused on today was Accreta, but we could talk more about other complications. It frees up beds. Relative to COVID-19, it frees up beds, it frees up staff, it reduces hospital stays, it reduces COVID-19 transmission, it uses less PPE, and really, the public health is at stake here. And it has been at stake in terms of Accreta and in terms of preserving fertility and reducing trauma that comes from Accreta, which is a whole nother thing that we didn't have a chance to talk about today. But it's at stake right now because birthing parents are terrified, and they deserve to understand what their options are, and they deserve to understand that elective cesareans and elective inductions are not recommended right now in terms of the time of COVID-19. We must improve VBAC access, and that is a real public health initiative that is close to my heart, and I know you all feel the same because you're here. So I want to take a few minutes to turn to any questions that were submitted via the presentation, and I'm going over to my spreadsheet now. How is perinatal mortality defined? Oh, that was in one of the studies. Perinatal mortality, I suspect it was 28 days, but I do not recall for certain. That is a good question. I do not recall for sure. Please note the location of the study of the high cesarean rate. I think it was China. It was China. Many of these studies are out of China just because of how quickly everything is happening. Are the recommendations for PPE the same for home birth? That's a really great question. I did not talk about birth in the home situation. I know that FAM, the Foundation for the Advancement of Midwifery, had a presentation on this very topic, and I would be curious to see what they had to say. What is the difference between surgical birth and cesarean birth? Well, to me, they mean the same thing. I mean, some people call their cesarean a surgical birth. Other people call it a cesarean birth or a cesarean section. There's many different ways that people refer to their cesarean birth, whatever that looks like for them. It's a really highly personal how people wanted to talk about their births, you know? So it doesn't look like we have any more questions right now. I'm just going to hop in the chat. Yes, someone said instrumental is different. Yeah, instrumental birth refers to either forceps or vacuum, as opposed to a surgical birth, which is typically, I mean, in my mind, that means a cesarean birth. So unless anyone else has any questions, I think we're going to go ahead and wrap it up today. Thank you so much, everyone, for attending, and I will see you next time. To learn more about the VBAC Facts, go to vbacfacts.com and check out our variety of trainings for parents and professionals that really expand upon and consolidate and collate a lot of the information that we have out there about VBAC. So thank you so much for attending, everyone. I love seeing all the feedback in the chat. Take care. Look for the email for all the handouts. I'll be sending that out likely tomorrow. Okay, take care, everyone. Thank you. Bye.